Good afternoon, everyone. I want to introduce you to the topic of my research, surgical insights on the inflammatory bowel disease management. My name is Mihaela Topala. I'm a gastroenterology specialist from Romania, and I'm also a PhD student at Davila University from Bucharest. And I am participating in a one-year fellowship of translational medicine with a scholarship sponsored by the MOL group. My vision is that in the next years, the morbidity will decrease and the quality of life will improve in IBD patients. So my mission is to evaluate endoscopical and surgical techniques that might improve the outcome in Crohn's disease patients. And for my mission, I'm currently working on 2 projects. For both of them, I will use the systematic review and meta-analysis methodology. The first project is effectiveness of extended mesenteric excision in preventing postoperative Crohn's disease recurrence, and it was started in September 2022. Crohn's disease represents a chronic condition that is characterized by recurrent flares of intestinal inflammation and complications such as stenosis, fistulas, or abscesses can be present up to 1/3 of the patient at the moment of diagnosis. Consequently, 70% of the patient will require abdominal surgery during their entire lifetime. And unfortunately, the surgery is not curative, and the postoperative recurrence rates are high, and many patients will require multiple interventions. Recently, some studies suggested that the mesentery might have a role in the Crohn's disease pathogenesis and progression, and that it might even influence the postoperative recurrence. So my aim is to evaluate the effectiveness of extended mesenteric excision in preventing postoperative Crohn's disease recurrence. To clarify the terminology, limited excision is represented by dividing the mesentery close to the intestinal wall, while in extended excision, the mesentery is cut close to the mesenteric root or to the major arterial trunks. For this project, my clinical question is whether extending the mesenteric excision is associated with lower rates of postoperative complications and postoperative recurrence compared with limited excision in patients who underwent Crohn's disease, patients who underwent intestinal resections. And for my clinical question, I used the PICO framework, and my hypothesis was that indeed this intervention is associated with lower rates. On 9 November 2022, I did a systematic search in 5 databases, and after the selection process and citation searching, I had 6 papers for 5 articles, from which 3 were included in the meta-analysis. This forest plots analyzes the postoperative surgical recurrence, which was defined as the need for surgical reintervention after the index surgery due to Crohn's disease recurrence complications. Considering the high need for surgery, and despite the fact that we are living in the biological area, the recurrence rates are still high, we need to find some new strategies to improve the surgical burden. So that's why we consider this our main outcome. And to measure the effects, we use the odds ratio with a 95% confidence interval. We included 3 retrospective cohort studies that totaled almost 500 patients. These studies mostly reported data from prospectively maintained databases with a follow-up between 47 and 69 months. As we can notice, all studies reported the same effect, and the study with the smallest number of patients reported the highest effect, the study of coffee, and we think that all these differences could determine the moderate level of heterogeneity of 45%. The overall odds ratio was 0.3. Clinically, it means that patients who underwent intestinal resections with extended excision were 3 times less likely to develop surgical recurrence. But our results are not statistically significant, so we need more studies to demonstrate this association. The second outcome is overall postoperative complication. For this outcome, we included patients who develop any type of postoperative complications. We have the same cohorts, the same 3 studies, and overall odds ratio was 0.78. That means that performing intestinal resections with extended mesenteric excision will decrease the postoperative complication rates by 22% compared with limited excision group. But again, we need more studies to demonstrate these results, since they are not statistically significant. So our study has some strengths, and I want to emphasize that it represents a comprehensive analysis following Cochrane methodology on an emerging topic in Crohn's disease surgery. But on the other hand, it also has some limitations. The first one is obviously the limited data. We only included 3 studies for meta-analysis, and moreover, all of them were observational cohort studies. And due to the small number of patients, to the high level of inconsistency and imprecision of the results, we have to downgrade the certainty of evidence to low and very low, respectively. In conclusion, intestinal resection with extended mesenteric excision appears to be safe, and it might have a positive impact on long-term postoperative recurrence rates, but at this moment, data is very limited, and the level of certainty is very low, so we cannot recommend it to be implemented routinely. But we have some implications for research. First of all, we need more studies, and we need multicentric with large samples randomized controlled trials. These studies also have to evaluate the impact on clinical and endoscopic recurrence, and we need subgroup analysis for different anatomic segments, for example, for ileocolonic or rectum. And in addition, we need to decipher the role of microbiome and immunological aspects of the mesentery. At this moment, we finished the manuscript writing, and it was sent to internal review, and I plan to submit the article by the end of the month. The second project is efficacy and safety of endoscopic balloon dilation for Crohn's disease strictures, and it was started in October. As we already know, the main concern in Crohn's disease is the high risk of complication, and studies reported that almost 60% of the patients will develop intestinal strictures after 20 years from diagnosis. Unfortunately, the efficacy of medical treatment is very limited, especially for the fibrotic strictures, so we have to perform invasive procedures, including surgical or endoscopical techniques. Endoscopic treatment is recommended, and I have to mention that endoscopic balloon dilation is the mainstay of the endoscopic therapy being recommended by the latest guidelines. So my aim is to evaluate the efficacy and safety of endoscopic balloon dilation in Crohn's disease strictures. My clinical question is, how effective is this procedure in decreasing the need for surgery for Crohn's disease strictures? And for this question, I will use the COCO-POP framework, where the population is represented by Crohn's disease patients who developed intestinal strictures. The context is performing endoscopic balloon dilation, and for conditions, we will assess post-procedural complications, short-term and long-term efficacy. And my hypothesis is that this procedure has a low rate of complication and high rate of clinical efficacy. And these aspects will contribute to the reducing the need for surgery and improving the long-term outcome. We had the preliminary research in December, almost 14,000 hits. There are some meta-analyses published, but also some new articles available, and we are still checking for feasibility. In the end, I want to submit my first project by the end of June and the second project in October, and I want to finish my presentation with my favorite inspirational quote: "Everything is theoretically impossible until it's done." Thank you.
Have you ever examined or do you have any data about the patient's nutritional state preoperative nutrition state, because nutrition state is very important for postoperative outcome, the surgical result. And the other is the preoperative treatment of the Crohn's disease. Do you have any data for the different conservative treatment that was used before the surgical intervention?
I will thank you for your question. Regarding the first question, there is only one study that reported the nutrition rehabilitation before the surgery. It was the study of Mihaela from Italy. And they mentioned that all the patients followed a specific protocol and had this rehabilitation before the surgery. But we don't have any data from the other two articles. So we don't know how were the patients treated before the surgery. And I think also a source of confounding for this project for the postoperative complication rate is the fact that the other two articles didn't mention that if the surgeries or in emergency or elective, that could contribute to the postoperative complications. And regarding the second question, they all mention the medical therapy that was administered before the surgery. Two articles didn't have any statistical differences between the groups, but I know that coffee had differences. I think patients who underwent extended excision also were more patients from that group were treated with biological treatment with anti-TNF.
How can surgically define what is extended and what is not, what is limited excision? By that I mean, you take out a little bit and, you say, yeah, 2.5 centimeters is still limited, and then 2.6 is then extended. So is there a clear definition which can be adhered to classify these patients two ways? Is there not a big gray zone between the two procedures?
Thank you for your question. At this moment, the topic is still new, so there aren't clear definitions for this type, but most of the studies reported that limited excision is when the mesentery is cut near to the intestinal wall. And for example, I checked for some randomized controlled trials that are still ongoing, and they choose a limit of 2 centimeters. And regarding the extended excision, they describe it as an operation similar to the cancer ones, where the mesentery is divided extensively until to the mesenteric root or close to the major arterial trunks.